Welcome to tonight's webinar. My name is Allie Webb. I'm a field marketing specialist for Axonics Therapy and will be moderating this webinar. This evening, Dr. Song will be speaking about bladder dysfunction, the common symptoms patients experience, and treatment options that may help you gain control. Without further ado, I would like to introduce Dr. Song.
Hi, good evening. Thanks, Allie, for the great introduction. And thank you for everybody for tuning in. I appreciate your time. I appreciate the opportunity to speak with everybody. A little bit about me. I do a pretty wide breadth of urologic care. However, if there's anything that's the most near and dear to my heart, it's the care that we can provide to improve quality of life. And so these lifestyle urologic procedures really are meant to help patients achieve the best quality instead of just quantity, right? I did, you see my education here, and I work mostly out of Duluth and Lawrenceville locations. So tonight we're going to be talking about bladder symptoms and the symptoms of overactivity. And this is something that really can significantly affect people's lives. And sometimes it happens so slowly and gradually that people don't realize how much it's affecting them, right? Whether it's what trips you can go on, whether it's the recreation that you can do, whether it's embarrassment to be with your friends or to do something active. You know, I had a patient who we treated who she had been so worried because her daughter's wedding was coming up. It was earlier this fall. And so we treated her over the summer. And I remember she came back and she hugged me and said, you know, I thought I couldn't make it through the ceremony without having to get up to leave. But after I finally got this thing taken care of, I was able to, you know, sit through and actually be part of this big moment in my daughter's life and not have to be thinking about where's the closest bathroom or am I going to leak if I try to wait another 5 minutes? So I think this is something that can significantly impact people's lives that is oftentimes underestimated. Part of it is that patients, you know, or people in general, this is a very sensitive topic. It's something that doesn't come up frequently in conversation. People oftentimes keep it hidden, don't discuss it, but it's very, very common. So overactive bladder affects millions of people across the United States. And it can like we talked about, have significant impact on their quality of life. So a little bit about overactive bladder and voiding in general, right? So there are multiple conditions that can affect the bladder. On one end, you can have overactivity, where somebody has the urge to urinate constantly and sometimes be unable to control or hold the urination. On the other end of the spectrum, you can have urinary retention, where people are having trouble emptying their bladder, they're leaving urine behind. And you can actually have a combination of both of these as well, where some people have trouble emptying their bladder fully, but at the same time, they're constantly going to the bathroom. So it can be somewhat paradoxical in that some people can have both of these conditions. Normal bladder function. So typically, the kidneys make the urine. They push that urine down through the ureters. Those gradually fill up the bladder throughout the day. The bladder is a reservoir. It's where everything is stored. As the bladder slowly fills based off of how much you're taking in, you'll eventually get the signal to your brain that, hey, it's time, right? I've reached this bladder capacity. Can't store anymore. You got to go to the bathroom to urinate. When those signals go through to the brain, that's when the bladder actually does a fairly complex song and dance. So it has to, at the same time, contract the muscles that squeeze the bladder down while relaxing the muscles that hold back the urine. And you can imagine through day-to-day life, running, walking, dancing, you can have quite a bit of pressure that's generated. So those muscles that hold back the urine have to be pretty strong and they have to relax well. And I actually take a little bit here to talk about the evolution of bladder control, right? So something that a lot of patients don't think about, or a lot of providers don't think about, is what's the default voiding status, right? So you take a newborn baby. How does that newborn baby pee? You don't pee like this, right? You don't fill their bladders and store and then tell their, their brains when to go. The default urination pattern is actually for the bladder to have this reflex arc. So when the bladder gets full, it'll decide to go on a signal of its own. It's only as we grow and mature that we get that control, that the brain establishes the pathways that inhibit the bladder. So ultimately, the correct function of the bladder relies on the brain being able to send signals all the way down to that bundle of nerves that control bladder emptying. And we'll get into why that's so important and what can go wrong in a little bit. So overactive bladder has multiple components. Overactive bladder doesn't have to be incontinence, and it doesn't have to be just urgency. So urinary frequency, typically we would say that if you're peeing more than once every 2 hours on a regular basis, during waking hours, that's usually a pretty good yardstick to say that you have abnormal frequency. Of course, frequency also depends on how much you're drinking. If you're drinking 1.5 gallons of fluids a day, yeah, you're going to be peeing all the time. But oftentimes patients will say to me, hey, I hardly drink anything. I really try to limit my fluids. I'm still running to the bathroom, more than once every 2 hours. And I think that's a pretty good indication that there's some urinary frequency there. Next is urinary urgency. So this is just the sensation that you need to pee. It may or may not be associated with actually going to the bathroom or having urinary leakage. It's just that desire to go to the bathroom. Thirdly, you have urge incontinence. This is where the urine is actually coming out on its own, right? So this is important to differentiate between urge and stress incontinence. With urge incontinence, it's you get the desire to pee, can't hold it back, have an accident. With stress incontinence, that's where you don't really have the sensation that you need to go, but you give a big cough, or you jump, or you do something active, and then you have some drops come out. So this is urge incontinence, where you're having that sensation of needing to go, and then the bladder just goes. And then lastly is nocturia. So nocturia, kind of to round it all out, that's when you're really going to the bathroom a lot in the middle of the night. Again, tied to how much fluids you're drinking, but typically if people are waking up more than twice in a night and it's bothersome, nocturia is something that may need to be addressed. So what actually happens with overactive bladder, right? So with overactive bladder, there is this abnormal sensation and communication between the brain and the bladder. And this gets back into, again, some of that kind of reflexive voiding that can happen, right? So the bladder has a loop that when it starts to stretch, it says, hey, we've got to go. And it's the job of the brain to say, don't go right now, not a good time, calm down, and it relaxes the bladder to allow for storage. All right. So when that connection is off, when that communication isn't going through, that's when you get a lot of these unwanted feelings of a need to urinate, and if that need is not suppressed enough, that's when you actually get the urge incontinence, where the bladder has a contraction and you have leakage. Of course, it sometimes results in not making it to the bathroom in time, and that can either result in a small amount of leakage or sometimes large enough to go through your clothing and to be very socially embarrassing. We talked about this briefly, right? So this is the difference between stress incontinence and urge incontinence. I find that in practice, most patients have some blend of the two, right? So again, stress incontinence, that's where the pressure inside the belly is building up, and the muscles that are supposed to hold back the urine just aren't strong enough to do it. When that happens, you get some urinary incontinence. It can be a small amount, it can be a large amount. Compared to urgency, when the bladder has a desire to go, right? And it's not that the muscle is too weak to hold it back, it's that that reflexive arc, right? That where the bladder decides to squeeze down, that's happening without your brain's ability to shut it down. And then some patients have a little bit of both. And sometimes you can have, a bit of urge incontinence triggered by stress incontinence. It's usually not just a black and white picture. Incontinence, it permeates all aspects of our life, right? It affects what we can do physically, right? How far away from a bathroom can you get? How long can you spend on a road trip, right? Can you go on that trip at all? It makes us, it can make patients, limited in terms of their social interactions, right? They worry about how they smell. They worry about, what their friends will think. And that can lead to a lot of psychological ramifications. Sexually, there's a fear that, sexual intimacy can sometimes trigger incontinence, or that there may be smell or affect how their partners may view them. It may lead to limitations in work in terms of both what kind of work you can do, but in terms of what work, what hours you're putting in, how long you can work for. And then finally, it really affects your day to day. You're doing a lot more laundry. You're having to go out and, buy Depends. You have to make sure you have all of these things on hand. And so we can see that in many, many aspects of our lives, urinary incontinence significantly affects the quality of our life. However, it's important to know that incontinence, it's not inevitable, right? So it's not just, you get older and you expect this to happen, right? It's not, you're a woman and that's just part of being female, right? It's not just if you're a man that your prostate's getting bigger, and it's not something that you did wrong, right? There's no, there's oftentimes a lot of self-incrimination, right? And that's not part of it at all. This is something that is more common with age, and that can be related to certain other medical conditions, but it's not inevitable. And likewise, there's many, many ways that we can treat urinary incontinence, and they really run the spectrum of multiple different therapies. So we have a whole pathway, and I love to guide my patients through this in terms of the escalating levels of care. And the important thing is that a lot of patients, they start down this pathway and they get discouraged. They try a medication that doesn't work, and then they stop. But the importance of talks like this is to say, look, there's many things out there, right? So number one, I usually start off my talks with my patients by talking about their symptoms, by seeing when their incontinence is triggered, by really trying to tease out those differences between the different kinds of urgency and overactivity that we just talked about. I'll always get a bladder diary at some point in the treatment to get a record of exactly how many episodes, right? And that's different for everybody. Some patients, they say, gosh, I really don't have to pee that often. But you get a bladder diary and you say, God, you're peeing every hour and a half, right? You're having 3 episodes of incontinence a day. And oftentimes those changes happen so slowly that you don't realize just how severe it's gotten until you really write it down. At this point, we'll talk about the types of treatments available. We'll do some tests. And as part of those tests, sometimes it's a pelvic exam. It may even be a camera that we look inside the bladder with. It's testing the urine for infection, making sure that there's not something else that may be triggering these symptoms. And then number 2, we'll talk about the types of treatment. Usually these start off with lifestyle changes, right? With maybe timed voiding, with exercises to strengthen those pelvic muscles. Oftentimes we talk about things in the diet like caffeine or spicy food that may irritate the bladder and trigger more frequent urination. And then sometimes we go on to prescription medications, right? And here's the thing with prescription medications is that these medications are not a take it for 6 months and the condition's gone away, you can stop kind of thing. These prescription medications are controlling the symptoms, but they're not necessarily fixing the baseline problem. And that means when you stop these medications, the symptoms may come back. And also importantly, some of these medications can cause significant side effects. The good news is that there's a whole new class of medications that's come out within the last few years. And so many patients who've tried prescription medications maybe 5, 10 years ago, there's newer medications available. And then finally, when medications and lifestyle modification and and changing fluids. When those things don't work, then we have more advanced therapies. And those are things like sacral nerve modulation, percutaneous nerve stimulation, and even using medications to block the nerve conduction. Next, well, we also have kind of, we mentioned this a little bit earlier, urinary retention, right? So this is kind of the opposite end of the spectrum where you're not having as much leakage, but you're unable to empty the bladder all the way. And in a similar fashion, there is this staged hierarchy of management, right? And so with urinary retention, we also talk about things like medications, but we also undergo a thorough physical exam. We look at the bladder, we look at the urinary pathway, and we see what may be causing this before we talk about the more advanced therapy options. So we talked about this briefly earlier. This is the really lifestyle changes that we can make, the non-invasive or less invasive options. Things like using techniques like Kegel exercises, retraining the bladder, doing time voiding, and sometimes going to pelvic floor physical therapy. This may be, it may involve seeing how much fluid you drink, right? Some people, they say, gosh, I was told that water is good for me. They go out and they drink a gallon of fluids a day, and that may really trigger a lot of overactivity and urinary urgency. And then there are things in the diet like caffeine, carbonated beverages that may also trigger your symptoms. And then lastly, medications. We talked about there's two broad classes of medications which can target the bladder and help the bladder relax and better do its job of storing urine. When those things have not worked or have worked, either not worked or caused too many side effects and can't be kept up with, then we go to the more advanced therapies. So this is one option that I offer my patients. And for some patients, this is a fantastic way to treat overactive bladder. So peripheral tibial nerve stimulation stimulates a nerve that runs through the inside of the ankle. By sending a stimulus to this nerve, it actually plugs all the way back into the sacral foramen. And this is where the nerves that create that reflexive arc, that reflexive voiding arc we talked about, this is where those nerves feed into the spine. By stimulating this tibial nerve, you can actually also stimulate some of those sacral plexus nerves. And so this is an in-office treatment. We typically do it for 12 sessions, about 30 minutes each. And then about halfway through, we'll reassess and say, gosh, is this helping? If it's helping, then we continue. After that, there is a maintenance program, right? So once this nerve is stimulated, that stimulus doesn't last forever. Typically, we do once a month stimulations just to keep this going. And for some patients, that's great, but for some people, it can be pretty onerous to have to come in on a regular basis that often. That leads to the next option for patients, right? So this is the injection of Botox, right? So most people think of Botox as getting rid of the wrinkles in your forehead and those laugh lines and those crease lines, right? The way it does that is it paralyzes those small muscles in the face that causes those wrinkles. And that's why you see some people who've gotten a lot of bladder Botox, their face is not as expressive because they can't move those muscles, but it'll get rid of those wrinkles. When we inject Botox into the bladder, it does a very similar thing. It blocks the function of the muscle at a nerve level. By blocking that function, we can get those muscles to really relax, right? To get it to open up. And that's where patients are able to store a lot more urine and go longer between urination and have less urgency. However, there's a few things you need to know about Botox. Number one is that sometimes it works a little too well, right? So in about 1 to 2% of patients, it works so well that they can't empty their bladder. And then they may swing from that overactivity into something like urinary retention. And in those cases, you have to wait for the Botox to wear off. And that leads to point 2, right? So Botox is not a one and done treatment. So typically, they'll need to be repeated every 4 to 6 months. As the Botox wears off, you'll start to see those symptoms come back, and then you'll need to come in for another injection. The good thing with Botox is it can be done very quickly. Usually just takes a minute or two. come in, you have the injections. I usually like to do the first injection under some anesthesia. And then if it works well, then we can offer patients to have this procedure done with just some local numbing medication. And my patients do very, very well with Botox injections. And lastly, we get to really the one of the most effective overactive bladder treatments we have, which is sacral nerve modulation, right? So this is where electrical signal is being sent to that plexus of nerves that feed into the bladder and into the sacrum, into the S2, 3, and 4 openings, right? This steady signal will help regulate the bladder's connection with the higher centers of the brain. And we do this in a staged fashion to make sure it works for patients before they commit to something long-term. All right, and this brings up Axonics. So Axonics is a company I've been working with for a while now. Fantastic company. They give some of the best patient support that I've seen with any technology company, really. They're on top of reaching out to patients, making sure they understand what they're going through, making sure to troubleshoot where those things, even though it's rare, they come up. And being available to help patients with something that is, a bit more technologically heavy than some of the other treatments, right? So what is Axonics therapy? This is a stimulation of that nerve, and it can help with both overactivity as well as retention and fecal incontinence, right? And it may seem counterintuitive that this would be a therapy that helps with both overactivity and urinary retention. But when you really think about this bladder and brain arc as a communication issue, right? You can see that when you have a breakdown in communication, you can have both ends of the problem, right? Either the brain is suppressing the bladder function too much, or it's not suppressing it enough. And that can also feed into issues with fecal incontinence. And so really Axonics can help with all three of these conditions. By stimulating that nerve, it helps restore normal connections with improvement in symptoms, right? So I'm going to play a little bit of a clip here from Axonics, and it does a very, very concise job.
Symptoms like yours can be caused by abnormal communication between the brain and the bladder or bowel, which disrupts your daily life. Axonics therapy provides gentle stimulation of the nerves that control the bladder and bowel, restoring normal communication to the brain and resulting in an improvement of your symptoms.
Like I mentioned earlier, this therapy is really done in steps. And that's because we want to measure how well these things work before we commit to a more permanent device, right? I like to do my first percutaneous test with just some local numbing medication. For this, patients will need to be able to lie on their belly for about 20 to 30 minutes. We put in some local numbing medication into the skin on their back. And then after doing some measurements, we're able to find that opening where that bladder nerve feeds into the nerves that connect directly up to the spine. It's important to note here that this is not anything going into the spine itself, right? These needles are putting in a wire that goes into that peripheral nervous system. In fact, the level where we work here, the spine has ended several inches above this level already. It's well away from this area. So there's no risk of injuring the spine or injuring any other nerves. By putting in a needle into this area, we can find the area where the nerve goes in, put in a wire, and then that is taped to the back, using temporary tape. And a power supply, which then gently stimulates this nerve. And we can find the settings that really get us the best stimulation with the least amount of sensation. And during this test, we're looking for a few things, right? So we're looking for a contraction of the muscles around the rectum. We're looking for some wiggling of the big toe and a fluttering sensation in the privates. After the initial test, we do a 4 to 5 day trial where we measure and see what is the response, right? What is the improvement or lack thereof in episodes of incontinence, and the degree of urgency, and how many times you're peeing through the day, how often you're having to go at night. And based off of that, then we can decide whether to move on to a more long-term solution, right? Because this temporary lead does have to come out at the end of a few days. If patients respond well, and about 90% of my patients have great response, if patients respond well and they want to proceed with that next stage in treatment, then there's two products that Axonics offers. One is a very, very small rechargeable device, and the other is just slightly larger that has about 15-year on average life expectancy that does not need to be recharged. Both of these are controlled with a very easy to use interface remote control. There's no fiddling with multiple settings. There's no complex routine you have to go through. You can just turn the program up or down. All right. And so, yeah, this is that first rechargeable miniaturized implant. You can see here compared to a quarter, this is about the size of one of those Andes after dinner mints. Really very slim, great profile, and it's designed to be recharged and to last at least 15 years. The important thing here, the big breakthrough that Axonics has, is that these products are MRI compatible, right? In the past, if somebody had one of these implants in and they had to get a MRI, oftentimes it would have to be explanted. It would have to be taken out surgically and then put back in at a later date. But now these with Axonics, we can get even very powerful MRIs, and there's no problem having this product in. This remote control, you can see, is very convenient. It's about the size of a car key fob. It's discreet, it's easy to use, easy to keep in your pocket. The charging system is a belt that you wear, right? And usually my patients will charge this about once every 2 weeks or so. Sometimes, depending on your settings, that can go even as long as a month. And most of the time it can be done when you're watching TV or relaxing. A very extremely easy to use process. And here's the outcomes, right? And so for my patients, it very much mirrors this kind of more long-term results. So these large studies show really the ease of adoption is very, very high, where 98% of patients are able to charge and to use these products without any problems. And you can see, Donna here, it's very straightforward. Oftentimes there's this fear that something is going to be very complex and hard to do, and really that's not the case here at all. So what's the result, right? What's the overall response rate? Right? So about 90% of patients will have a significant improvement in these symptoms. And that's a durable response. So 2+ years out, you're seeing 93% of patients having significant improvements in their quality of life and their urinary control, and decreases in the amount of times they have to go to the bathroom. And you can see that is reflected again with patient satisfaction scores. All right, really, I've had many patients come up to me afterwards and say, this procedure changed my life. It allowed me to have my life back again, allowed me to have control again. And I'm excited to be able to offer this to patients and to really get a handle on these problems.
Thank you, Dr. Song. It was a pleasure hearing from you and your experience with treating patients suffering with bladder dysfunction. At this time, we are also going to open up the Q&A session. Okay, Dr. Song, does it hurt?
So the short answer is no, right? During the initial percutaneous test, there is some discomfort, right? However, that's a very short procedure, and the benefit of not having to go through full anesthesia to have that test done, it takes just about 20 minutes. You'll feel some pressure. You may feel an electric sensation while we're doing that test. If that works well, and then again, it works well for about 90% of patients, then that stage 2 is under full anesthesia. And there really, there's no pain. The recovery is very, very minimal. Most of my patients come back and say they didn't even need to take any of that pain medication. So this is a very easy process to go through. It's not a very painful one at all.
Okay. Where does the procedure take place?
Good question. Yeah, so that first stage, that first step is done at the surgery center. You don't have to go to the hospital. There's no big check-in process. It's at a surgical center with some local numbing medication. I do like to do the permanent implant in an actual OR, and that allows me to just make sure that we have the level of sterility, level of control, and of course, we have that anesthesia for the patient so that they don't have to be awake while we're doing the more permanent implant.
How will I know if this is the best technology for me?
Yeah, good question. So in terms of ways to treat overactivity, right? I think it's important that patients walk through all of it first, right? Because by the time we arrive at something like sacral nerve modulation, this is a more permanent solution, right? This is a more permanent treatment. And that's one of its pluses, that you don't have to remember to take a pill every day, that you're not having to, struggle with, really counting how much fluids you drink. But I do think it's important to work through that whole process to see what else is there. In terms of the technology itself, I think the quality of Axonics really speaks to itself. The interface is easy to use. We do this test to make sure that it's working well for patients before we commit to anything. And the support from Axonics has been top notch, right? The reach out, make sure the devices are working perfectly, that patients understand what settings they're using. And there's really that patient-provider partnership through Axonics that I think is the biggest strength of the company.
Thank you. Does insurance cover it?
Good question. So every insurance company that I've worked with, Medicare certainly covers it. Private insurers, everybody that I work with, every insurance that I accept has covered. I've had no issues with coverage. Now, we do have to go through that process, right? So patients do have to have a certain amount of response. And so when we look at the urgency, the frequency, nocturia, the number of episodes, at least one of those four needs to have a 50% improvement for Medicare to cover this treatment. And I think that's important, right? We don't want to be putting a more permanent device in a patient if it's not going to help them. Ultimately, as long as this is something that's controlling those symptoms of overactivity, it is covered by insurance.
Will prostate conditions such as enlarged prostate or prostate cancer have success with some of the treatments mentioned here?
Yeah, absolutely. Good question. So enlarged prostate has significant effects on the bladder. And if you've seen me in the office, I talk about this ad nauseum, right? Your bladder is a pump, it's pushing fluid out of the body. And an enlarged prostate is a clog in the pipe, right? That clog can affect the pump over time, right? It's downstream, it increases that pressure. And so, yes, patients who have enlarged prostates oftentimes do have some overactivity because their bladder has been so stressed out for years working against this blocked system. For patients with prostate cancer, similar thing can happen. You get radiation, that radiation goes in and affects the bladder. It can affect the nerves that control the bladder. You can have quite a lot of overactivity and urgency. Now, with prostate cancer specifically, I think it's important to have some distance between times of treatments like this, when we offer this treatment versus when the radiation was done. And that's because some of those radiation symptoms will evolve over time, right? If you're 3 months out, 6 months out from your radiation for prostate cancer, you may have a lot of overactivity, but oftentimes those things are transient. And we don't want to rush into a treatment like this for symptoms that'll improve by themselves.
How do I schedule an appointment?
That's the easiest part. So if you're interested in an appointment, we have got the contact information here. But also, that survey that you fill at the end, we can certainly have my office, have my staff reach out and set things up so we can talk about, the holistic treatment of overactivity, including finally something like sacral nerve modulation.
Thank you. What is the longest that any of your patients have used this device/procedure?
Yeah, so I've gone in at 10 years and exchanged these devices out, right? And so I think we had an earlier slide talking about the expected lifetimes of these devices. So these newer generations like Axonics last a lot longer. They last 15, 20 years sometimes, right? But those first generation of devices, sometimes the battery will wear out. Sometimes it's in under 10 years, and then you need to go in and replace it. Yeah, so I've seen patients who have had this in for 10 years, 10 plus years. I have a patient who I didn't put his initial implant in, not quite old enough to have done that, but he was one of the first ones who got this done in the Metro Atlanta area, and he is on his I think his third battery now, and he's had it for over 20 years and loves it. It's really changed his life.
Is this for both men and women? And is there an age limit?
Absolutely, it's for both men and women. There is no age limit. I think for patients who cannot undergo anesthesia due to risks associated with age or other comorbidities, we can do that stage 2 implants, even under spinal or local numbing medication. Typically, we do it asleep. I think that works a little easier. But really, we can offer it to patients of any age. And absolutely, this is something that affects both men and women, right? The process of what may be the root cause is a little bit different between men and women. But ultimately, this overactivity, we see this in both genders all the time. It's a very common finding in both.
Is there any benefit of having a chargeable versus non-chargeable battery?
For sure. Yeah. So when you have that rechargeable battery, it's much smaller, it's much slimmer. So for patients who are very skinny, sometimes the larger device, you can feel a little bit more underneath the skin, especially if you're lying down on a hard surface. For patients who maybe don't have the best manual dexterity, who are more wary of having to deal with that charging, or who lead a lifestyle that I just can't, I'm not going to be able to charge it on a regular basis. It may be better to have the battery that does not need recharging. And then lastly, I think it's important to see what settings we settle on that initial test, right? So somebody who needs a little bit more stimulation, who may be running through that battery a little bit more, it may be tougher for them to charge. They may be needing to charge once a week, right? Whereas that longer battery can last them 10, 15 years without needing any regular charging. Sure.
Can spondylosis affect bladder control?
So spondylolysis,
There you go.
it can affect the nerves that come from the spine, and that in turn can affect bladder control. However, the fix for that is oftentimes related to fixing the issues with the spine itself, right? Where we are affecting these nerves, they've already left the spine. And so if you have a issue with the curvature of the spine, or with the a herniated disc within the spine, really that is a separate fix that should be done kind of outside of the setting of sacral nerve modulation. And those baseline issues should be fixed first before we turn to something like this.
Thank you, Dr. Song. And that brings us to the end of this evening's webinar. Thank you, Dr. Song, for your time. We hope that the presentation was beneficial. If you would like more information or to schedule an appointment, please call Dr. Song's office. Thank you for joining us. We hope you enjoy your evening.
Thanks, Ali. Thanks, everybody.
Thank you.
Have a good night.
All right, good night.